They're now starting to conclude that there is a link between calcium supplements and coronary calcium. At first we thought it was just because it wasn't linked to D, and then the second and third study came out, they were linked to D and the type of supplement that many people are taking. So what we recommend people do is get 600 milligrams of calcium from typically like a multivitamin or something like that has about 600 milligrams of calcium in it. And then get the other 600 milligrams of calcium from a low-fat or non-fat dietary source. And that is splitting the difference, and we think keeping people safer.
I'm sorry, vitamins D and K, I hear about them, seems like lately. I don't know if that's old news or...
Vitamin D, I actually had a little randomized blinded pilot study looking at vitamin D and statin myalgias. And I just had a couple interns present some raw data, and it was interesting. In my little group, we saw a nocebo effect, which was interesting, but they did have lower LDLs in the vitamin D group, so it was only 20 people, hard to discern. Basically, what we feel as scientists who have an interest in vitamin D is that low vitamin D levels typically seem to be more of a symptom of something else going on. Because if you think of every single disease process, they've been able to link low vitamin D to it. You fix the low vitamin D, you still have preterm delivery. You fix vitamin D, you still have a thyroid problem. You fix vitamin D, you still have a rheumatological disorder. So it's likely a symptom that something else is going on. We're still doing studies looking at mitochondria and vitamin D and muscle metabolism and those kinds of things. We might find something, but as of right now, I think 15 minutes of full body sun exposure is a good way to go, and some foods that are fortified in vitamin D. Basically, if you can eat it and not have to swallow it in Pharmacist, sorry I didn't put it together, it's better coming from Mother Nature at this point. Otherwise, we love our FDA-approved medications. I wanted to just put this up just to give you a little bit of preface around how complicated our blood vessels are, and our coronaries in particular. Our coronary arteries are literally living, breathing. They vasodilate, they vasoconstrict. We think that there are some traditional and non-traditional risk factors here that likely predispose people to chronic inflammation, and this risk factor clustering starts to cause some positive remodeling and some atherosclerosis. This is kind of where the calcium score starts to come into play. And then we start to see people start to exhibit their symptoms. Endothelial dysfunction. The endothelium is basically the skin of the lining of the blood vessels. And when it is dysfunctioning, it can actually cause the blood vessel to vasoconstrict and mimic what looks like a heart attack, but it's actually a type of spasm. And then if you see down here, people's quality of life and their functional capacity start to reduce. And unfortunately, we have multiple studies that have been able to demonstrate that women can have normal or non-obstructive coronary artery disease and have a lot of heart attacks and die from heart attacks, or have ischemia from heart attacks. So about 50% of patients can have persistent chest pain, so they're having chronic chest pain all the time, most of the time, and they don't have a flow-limiting lesion that is causing a blockage. And it's because of the physiology that I was alluding to. They can have constriction, they can have dilation, they can have an atypical type of presentation, such as a Takotsubo cardiomyopathy. Some of you might have heard of this. It's got 25 different words that describe it, but it's basically broken heart syndrome. You watch a family member get in a car accident and you can have a heart attack. We have different ideas as to why that happens, whether it's that endothelium just clamping down, or it's more of a smooth muscle response, which is coming from the vessel wall itself, that there is a vasoconstriction that happens, and the heart balloons out and looks like a Takotsubo, which is a Japanese word for an octopus pot. Spontaneous coronary artery dissection is unlikely, but we do see it, especially in areas of, tertiary, higher level care. Young women with sometimes showing up with a Hollywood heart attack, but they're 28, 30 years old, young women. They have a 10 to 15% reoccurrence rate, but this is a tear. It's a tear in the coronary artery. We deal with all kinds of issues around these women not being able to get pregnant and have children and have other issues. There's lots of discussions around some of these atypical types of presentation. Our center, we're world experts in coronary microvascular dysfunction, which is the microvessels, the ones that you can't see to the naked eye, that will actually start to constrict instead of dilate when they're supposed to. And we, in an invasive angiogram, when they put the catheter into the heart and they can drip down 3 different types of medication, all are known to have vasodilating or opening up the blood vessel effect. And women with microvascular dysfunction, actually, their blood vessels stay the same or even vasoconstrict. And so it tells us which vascular bed actually, depending on what medication they're having an abnormal reaction to. And then we can personalize medicine, their optimal medical therapy. Now, when we think about traditional risk factors as to why people would have all those abnormalities with their blood vessels, men typically have more hypertension and smoking, but when it's present in women, it poses the same risk as men. As I had mentioned before, cardiovascular rates are high, in particular for diabetic women than men. Women have elevated triglycerides and low HDL, which is the happy good cholesterol. Typically this is happening starting around menopause and when our metabolisms start to slow down. And we see more total cholesterol and LDL, but it poses the same risk in men when men have the same issue. So, metabolic syndrome, clustering of blood pressure and lipids and all of these types of things, polycystic ovarian syndrome, elevated C-reactive proteins, carrying around more fat around your waist as opposed to your hips and your buttocks, which is actually more of a cardioprotective type of a pattern. I'm reiterating this just because I had heard about the symptom issue and it being missed. But here are presentations of women who are having heart attacks, and they typically cluster. So most women, when they're reading our board, they'll go, I have had all of these things. You're looking for clustering of it. So you're having back pain, you feel like you're having the flu, your stomach hurts, your jaw hurts, you're sweaty, somebody looks at you, says you look kind of pale. You're winded, and you're sitting there, and you never are winded, and the whole, my favorite, excessive fatigue one. You want to always refer this person to an emergency room first. It's always okay to go in and have them do an EKG and a single blood test and have everything look normal, and then send them home. You can order them a Z-Pak later. But you don't want to miss the opportunity of finding somebody dead in front of a television.
So can I just ask you on a practical basis, as someone who's gone into a primary care doctor and with chest pain and family history and all that, I think we need a protocol to make it easy for primary care to know what to do, because they honestly they don't know the issue.
Right.
And so in the case of Steve's aunt,
Right.
should it be an EKG right there on the spot, which is what
Yes.
they did for me, and they were just really stunned.
That's national guidelines,
But-
is an EKG with chest pain.
But they look
And
at a young
An
woman,
emergent referral.
and if you don't have chest pain though, and you
Right.
have these other things,
Right.
isn't it very cheap just to do an EKG right
It
there on the
is,
spot?
and there's a reason why when we look at, and I don't think I showed this for sake of time, but when we look at mortality rates, they're all going down in cardiovascular disease across the United States, except in women 36 to 54 years of age. In the ERIC study, very large database, more women dying of that age. for a multitude of reasons, but a lot of it, education. Remember I was telling you, if you're having any symptom above your waist, man, woman, go get it looked out and have them rule out the scary stuff first. And it's real easy to do. EKG, troponin.
Yep.
And if it persists, go back. And we need to embolden our patients to be their own advocate for their family, for themselves. And if you have a healthcare provider saying something to you and it doesn't sound right, you need to go find someone, just keep going back. Because we've seen so many women that they wouldn't be alive here today if they hadn't gone, sometimes we're a fourth evaluation for them. And we find a good old-fashioned obstructive heart disease just in a 40-year-old.
Margo, can I ask, so my first passion was ER. I was
Yeah.
an ER nurse for many, many years. And I've also worked in like the open heart
Yeah.
unit and a lot of different things. I worked at White Memorial and
Yeah.
I remember a time when a lady came in, 36,
Yeah,
and we did not catch these symptoms. So it became like, it was very traumatizing, I
it
think,
is
for a lot of us.
traumatizing.
And so Brian Johnston, who was
Yeah.
the chief MD over there, he did some of the training himself and saying, hey,
Yeah.
when women come in, they come in with different symptoms.
Wonderful.
Is there anything, but that was him, like
Yes.
addressing this very,
It's why I'm standing in front of you today.
so are there any
we-
protocols though, like?
We
because I
have
think you're right,
protocols.
we need a.
There are
we need a
national,
ER.
yep, there are national guidelines. The problem is if you look at these national guidelines, they're usually 120 to 140 pages as an author of some of these guidelines. We try and do a quick and dirty one page, and things for medical students to be able to carry in their pocket. But the moral of the story today, when you walk out of here, is to remember is that anything that is happening above the waist, nobody died of a hernia, nobody died of GERD, nobody died of a panic attack, even though sometimes it mimics and it sounds like a heart attack. But people die of heart attacks, and people are severely, the worst is you don't die of a heart attack and you're severely debilitated and you don't have family around you to support you, and you end up in a skilled nursing facility and you're there for 30 years. There's no reason for it. So if any of you are anywhere and you wanna have some, I'm happy, we have a large team, always happy to come out, we give talks. I was saying, I'm on the road, like I'm on a plane every week till December, but this is what we do. And I try to get into larger venues, like right now I'm really targeting primary care, physicians, nurse practitioners, there's some endocrinologists and some OBGYNs there too, which is always awesome. And they're really hungry for cardiometabolic talks. And so that's what we're really trying to focus, and then we're getting into atypical symptoms. I applaud the American Heart Association and the American College of Cardiology for putting the pregnancy disorders, the premature menopause in there for the women, because those weren't even considered, even though we knew about it for many years. Yeah. And then unfortunately, did I mention that half of women don't even have an alarm system? So if you think your alarm system is screwed up because you're having excessive fatigue and shortness of breath, the other half of women aren't even that lucky. They're having no symptoms. And Dr. Merz's next door neighbor, she was in her 40s, and they thought she had the flu. And she had 3 little kids, and they found her dead laying on the couch. Thought she had the flu. I think she was on a Z-Pack.
Oh dear.
So,
But let's stop with that and just say what should have been done differently. So we're hearing stories and stories and stories like
Yeah.
this. So there should be a protocol for primary care. By the time somebody gets to cardiology, it's in half the cases too late.
so like I said, for primary care, they need to know, they know certain facts about a lot of different conditions. I think that what we really try and focus on is bringing them up to speed with these atypical types of symptoms. and what are risk-enhancing factors and what are traditional risk factors. And then as consumers of healthcare, which we all are, we need to empower ourselves and our patients and our family members, which is why I have said your family members multiple times today, that if people can't rattle off to you at the next birthday party what their LDL is and what their systolic blood pressure is, or not have a ballpark idea, then Houston, you have a problem, because we can hammer at the primary care doctors all day long, but until we go to Congress and we empower patients, and we have a real movement, it's not gonna change. Because it's not just one body of it doesn't lie with one body of people. It's a health disparity. And it's a healthcare issue. It's not a medicine issue. Truly. Sorry, I've been on a serious soapbox.
You're perfect for RightCare. I'm surprised it took us this long to meet you.
And here's another thing, women, their exercise tolerance really significantly goes down. And then, we get into multiple reasons why you can have chest pain. So I know I probably terrified half of you and you all feel like you want to go for a stress test. This is a diagram as to why you're scared. Further validation. There are a multitude of non-cardiac reasons why you could have symptoms above your waist. And then you can see along the bottom here, these are the open coronary reasons why somebody would have chest symptoms. So getting yourself the right stress test is really important. So what is the right stress test without over-radiating people and overburdening our healthcare system? Well, can the patient exercise? Yes or no? Is their baseline EKG okay? Do they have a bundle branch block of some sort or some kind of other abnormality that would not allow us to read their ST segments? If they can exercise and they have an otherwise okay looking EKG without a bundle, then throw them on a treadmill and have them run. And I also tell my patients, even at Cedars-Sinai, if that fellow stops you and you barely got started, I want you to try and elicit your symptoms. Try your best. Run as hard as you can if they want to stop you, but you're not satisfied that you're not feeling the way that you feel when you're on your walk and you're having the symptom, tell them you want to go further. And then we start to see things. And, so eliciting symptoms, looking for EKG abnormalities. And if you're having an ST segment depression that is horizontal or kind of straight, this is a part of the EKG that we're looking at, then that's considered a positive aspect of the test. If you have symptoms, that's a second positive aspect of the test. And then which measures your overall functional capacity, which is a direct measure of mortality. If you can't go up over 6 METs, which is this functional capacity measure, that's not normal. And either the person is severely deconditioned and out of shape, which sometimes happens, but sometimes you're missing triple vessel disease. And then you're having, a different kind of we had one of my patient's daughters had that. I carry her obituary with me every time I go to Pete Stark's office, and he starts to go off on CTA scanners being too expensive for the right person. If they have an arrhythmia on their EKG, or if they have a really hypertensive response to exercise. These are all things that if you're looking at more than 3 of these things, that would otherwise be considered at least an equivocal or positive stress test. So what happens if it's inconclusive and you're still having persistent symptoms? Then that's when we start to bring in an imaging component. We love our stress echo at Cedars. It's a recumbent bicycle protocol. We catch a lot of stuff on it because the traditional one is usually you'll run on a treadmill and then you have to carefully get off the treadmill without falling and face planting and then laying down on the bed. And if you're actually a pretty fit person who has heart disease, your left ventricle can reperfuse by the time you're lying down. That's what happened to one of our patients. But when they're pedaling on a bicycle and you're ultrasounding their chest, then we can see if there's any dyskinesis or akinesis or lack of movement of this of the left ventricle. PET-CT in a good center is an excellent test, especially for those people who cannot exercise and we want to look at the microvasculature. At Cedars, we can look at coronary flow reserve with PET-CT. We can also get a CAC score, which is a coronary calcium score. So lots of bells and whistles with that one in the right hands at the right center. And then we've really kind of mastered the adenosine cardiac MRI, which looks at perfusion. So this is a functional physiology stress test, if you will. So we look at blood flow. So it looks at anatomy, but we can also look at the flow of the cell, the endocardium, which is actually the sac of the lining of the heart, and that's where the microvascular dysfunction really lies. And then, and I just put it down here just so I can say it, we do coronary reactivity testing, which is a special type of angiogram where they drip down those medications, and then we can directly test the arterial bed. That's the gold measure for being able to assess vascular function, in particular for people who have open coronary arteries and they've had a heart attack, or they're young, or they're really debilitated by their symptoms. So, I've gone over my time.
Is that okay with everybody? I don't think a single person is left, so.
My conclusion slide is the nutshell of basically everything that we just talked about. We really need to focus on our minority groups, our minority women. They're really hugely disparate, and we really need to optimize what we know. There's no rocket science around risk factors. Everybody should know what theirs is, and if you don't, you must. And your children must, and your parents and your grandparents must. Moving your body through space for 30 minutes a day, doing whatever it is you love to do, and avoiding those supplements and eating out of the Mediterranean, which is more of a style and not really a diet. And optimal diagnoses if you've got symptoms above your waist of any sort. Don't take no for an answer until somebody sits down with you and gives you really good rationale as to what it is and you feel satisfied with it. Because typically your gut is best, and it oftentimes will save your life if the other team doesn't. And I love this picture. This was our Go Red Day a few years ago, and the camera people brought boxing gloves, so we were kind of having fun with our little props and media attention and trying to get the word out constantly. If you have anybody that you know that needs a little extra treatment and evaluation, I did add our clinic number there, and please feel free to say that you met me and that you heard the talk, and we'll emergently fit people in. And with that, I want to thank you for your time and your attention, the wonderful discussion, and congratulations on all the great work that you're doing.
Do you have a few minutes
I
for
do.
questions?
Yes, I do.
In case anybody has questions?
What can you say about the low-carb, high-fat diet?
Yeah, it is unfortunate because it promotes an inflammatory state, so you're not only just promoting heart disease risk, you're actually promoting cancer risk as well. We know that saturated fats, there's a cascade of different kinds of fats. We've learned a lot about them in recent years. A big problem here in Los Angeles in particular, where people think that carbs are the devil and that any kind of protein is fine, even if it's wrapped in bacon, and that's just simply a non-truth. And you have to think about more anti-inflammatory. Pretty much anything that you do that's good for your heart is good for cancer prevention too, because these things are all inflammatory processes. So a big one is coconut oil. Talk about high fat. People don't necessarily think about tropical oils, but it's such a problem that the National Lipid Association had to come out with an impact statement on it. You can slather it in your hair, you can put it on your face, you can, just don't eat it. Don't lay out in the sun with it either. It is essentially Mother Nature's Crisco. It is, it converts into a trans fat at the drop of a hat with any remote heating at all. And if a general rule of thumb is if you're looking at something that is a fat and it is not liquid room temperature, stay away from it.
Can you
Well-
share your slide deck?
Yes, yeah, happy to do that. I have it here actually, so you guys can feel free to have it.
So we posted on our webpage, all of our slides, all of our videos are posted within a few days after each session. We can't normally pick up the conversation, but we can usually hear the speaker pretty well on those videos.
Yeah,
So I guess I have one commitment question, and that is, would you be willing to work with us on some practical protocols that our health systems can adapt?
oh, definitely. I have a lot of standardized protocols. If you've noticed, I'm a nurse practitioner, and we're quite good at utilizing protocols. I think not just nurse practitioners should use protocols. I think everybody should, unless they have, like I do. I see some very unique things, and so I have a very sound rationale with a reference when I deviate from it. But yeah, I would love, yeah, anything that's Dr. Ron Victor's hypertension protocol. I have a pretty cool dyslipidemia protocol. I actually specialize in people who have side effects to statins. I have a strong interest there and have a protocol for that. But you guys, if you can help me reach Medi-Cal,
That should be
Women.
pretty easy. If you want to talk with us afterwards,
and get them
We'll
into
talk
our
about that.
study, if anything, we really are desperate to get our hands on them.
Any other questions? So we will see you back here for a session on advances in cardiology on October 17th. Dr. Matthew Budoff will be coming in along with Victoria Dupuy, who started No More Broken Hearts. And since she last spoke to our group, she has started after losing her 43-year-old Apple engineer husband to a sudden MI while he was playing hockey, she started a mobile CT unit up in Silicon Valley. And she's going to give us some early results along with Bob Trine, who is our new operations manager for RightCare for LA. They have done a study and we'll learn about those who have especially coronary calcium scores above 1,000, and we'll hear some practical cases. For instance, she was telling me up at Stanford at our meeting 2 days ago that in their mobile unit, one of the cases, somebody was found with a score of 800, and their primary care doctor said, you don't need to do anything about it,
Oh, goodness.
and did not, so that's why we need protocols.
Right, and the problem is with that is it's usually the ordering provider that is responsible for the result, and so you're deviating a little bit from the standard of care when you're out in the community and people can self-refer in, and they've kind of intervened out of the protocol. Dr. Budoff and my team at Cedars-Sinai, we have a study called the Warrior Study together, and it's sponsored by the Department of Defense, and it's looking at people who have had a CT angiogram or an invasive angiogram and had less than 50% blockage, but they have current symptoms above their waist. If they can go into this study, that's optimal medical therapy. It's really tailored towards women, but even if they haven't had a CT angiogram, we do our CT angiograms with Dr. Budoff to further qualify them. A lot of people, they've had an angiogram 10 years ago that was clean, but it wasn't 5 years ago. So if you have any patients or if you know of anybody that would value getting a CT angiogram for free of charge and they've been told their arteries have been open in the past and they're having some symptoms, it's kind of a great free way of getting evaluated with a nice bells and whistle test. And the phone number there, you can reach us there too for it's called the Warrior Study. Easy to remember, Department of Defense funded.
Margo, can I ask you one question? Are you familiar